Shall I?
Yes, sir, please.
Yeah.
Sorry.
No, not.
Please go ahead.
The as again from I am IMMAST. Definitely, I am thankful that we have associated and we are interacting with each other for on this topic of newer horizons in bariatric surgery. Our thinking is that as we grow, as we immerse ourselves into, for example, bariatrics, then lot of things have to be learned. It is not that only sleeve or only bypass or only, so many things can be learned, and so many things can, obviously, one should carry on learning. One should never ever become a learned. That is our thought. One should carry on unlearning, learning, and relearning. And in this topic of newer horizons, I am mainly focusing my talk of next 20 minutes onto the robotics system. That all of us know that open was the version 1.0, and then laparoscopy was version 2.0, and robotics has been version 3.0. And next era, which is not the next now, it is the present era, it is the era of intelligent surgeries. Intelligent surgery, in the sense that ultimately artificial intelligence is going to take in a big way, and it is going to make a difference. So anyone who has not gone in with the technology will be left behind. So our especially for younger colleagues, you should decide whether you belong to era version 1, 2 or 3 or 4 and go accordingly. When can you imagine that it was said too big, too expensive, too dangerous, lack of proper training, it will never become accepted. What we have now is fine. And what was this told about? This was about the automobile. This was about, in 1925 about the aeroplane. And in robotics also, so much of criticism was there that it is too big, it is too expensive, too dangerous, it requires lot of training, lot of docking time, undocking time, and so on and so forth. But believe me, it has grown. And when we got the first robotic system in Gangaram Hospital in 2012, and still it is progressing very fast. Now all, even the surgeons, the gynecologists, the urologists, the thoracic surgeons, all of them are using, and the numbers are going day by day, they are increasing. Similarly, in 2018, there were more than 1500 peer-reviewed articles, and now can you imagine that 6 into 10 to the power 6 procedures have been performed. What I mean to say, even if people say that the robotics is not going to stay, it is too expensive, too difficult to learn, but in US, few years back, robotic prostatectomy, radical prostatectomy was the commonest procedure. But once the gynecologist took over, now the robotic hysterectomy has become the commonest procedure in US also. And time is going to come. Now, frankly, my son is in Da Vinci, in the intuitive surgical in San Francisco. They have been working on general surgeons a lot now, and then they are encouraging that ultimately again it will go back to the general surgeons when they will be doing lot of bariatrics, lot of abdominal wall reconstruction robotically. So what I mean to say, the time is going to jump on, and if some of you young ones, you ask me that what is the best thing to do today, I think if you can catch hold of the fellowship in US about the robotics, about the bariatrics, and about so that ultimately you have so much of exposure about the artificial intelligence, you are going to rule the next 3-4 decades. So our thinking is that yes, we should go with the time, and time is not far off that general surgeons will again take over from the urologist and the gynecologist, and the procedures are increasing day by day. And even the robotic installations, initially any and everyone, now you see even in India also the numbers are increasing day in and day out, and the lot of, because of the competition also, because of the CMR, because of the other Medtronics and other companies also chip in because of the competitions, all of us will grow. So our thinking is that please open your mindset. Don't think that it is not for me. Ultimately, it is going to come. It has come. It is the present. And if you are able to learn, if you are able to board the flight earlier, you will definitely have an excellent time. And believe me, there are n number of studies that it proves that it has better outcomes, better patient experience, and plus patients are asking for it. That is also a situation. Even for example, when laparoscopic cholecystectomy, Dr. Raman and me and Dr. Ismail would remember, when laparoscopic cholecystectomy started, then many people used to say that it is just a fad. When Dr. Bhatia presented 56 cases in Delhi in CICD conference, then I was also surprised that how can it be done by laparoscopic method? Gallbladder could be removed by in 92, 93. And now all of us know that it has been patient driven first, and then literature driven, and then it has become the order of the day. So same way, ultimately the cost will come down and the patients will be definitely are going to be benefited, and it is becoming one of the tools. I would never ever say that it is a different. And again, if you are doing laparoscopic surgery, if your hand-eye coordination is good, then learning robotic surgery is easier than learning laparoscopic surgery. Believe me this. And there are n number of urologists who had never laid their hands onto the laparoscopic equipment, but they are able to do excellent robotic radical prostatectomies, robotic VVF repairs, and so on and so forth. So ultimately, answer is that one does not take much time, much energy, because all of us are learners. And advantage is that it is more of a intuitive. What is intuitive? What do you mean by literal meaning of intuitive? Anyone? What is the literal meaning of intuitive? Intuitive is instinctive. That it is the instinct. It is your instinct that you will do like this. And if you sit on a console and if you have a three-dimensional HD vision and you have a endo-wristed movements. Why Dr. Raman Goyal was also asking why we are doing it in bariatric surgery, in robotic bariatric surgery for 80 BMIs, 90 BMIs is because it is too instinctive. It is three-dimensional and it has got the maneuverability. Maneuverability becomes very easy, that you sit on the console, you are having two fingers, one foot busy, and that's all, and you are able to replicate the movements in the patient. So our thinking is that because of the torque, especially of the obese patients, so much of torque was there, even if I was using the long instruments, 45 centimeters laparoscopic instruments, but still I had to struggle on my shoulders, and patients obviously had pain later on and whatnot. But once we adopted to the robotic system, it definitely helped, and helped to that extent that ultimately we are able to offer them this kind of surgery, this kind of the benefits, and these advantages, the ergonomically, and plus most important benefits for, especially for our age is also that I think that I will be able to operate till the age of 88, 89 when I am going to die. What I mean to say, previously the surgeons, the open surgeons would have quit the surgery at my age, and if the laparoscopic surgery will have to quit at the age of maybe 70 or whatsoever, but in the robotic system they will carry on operating till the age of 90 or, and only thing is limitations are only in the mind. Our thinking is mind has the limitation, nothing else. So people used to blame robotics that they do not have the feedback, tactile feedback. I also say now the progress is going on that when the visual cue is providing you the feedback, tactile feedback also, visual cue. But the equipment, they are working on haptic feedback. So ultimately in few years, haptic feedback will also be available. One. Second thing is that, for example, it is a bulky equipment. Now we have seen, previously we had the SI model, now it is the XI model, the size has come down. Similarly, all of you would remember that Motorola mobile phone we used to use, and it was too big, and we used to wonder how such a big mobile phone will be prevalent everywhere. Now all of us have seen that so much of beautiful all cameras and everything has been jutted onto the mobile cameras, onto our phones. So our thinking is that ultimately let us go over that limitation in mind and adopt in such a situation, so that ultimately we are able to go in and do the advanced. But believe me, I am not going to sell or tell that for everything the robotic is the answer. No, robotic is not the answer for everything. The laparoscopic surgery has a place, open surgery has a place, the robotic system also has a place in such situations. For example, I have always been insisting on access the inaccessible. For example, the prostate was not accessible to the laparoscopic surgeons, so robotic surgery has helped. So access the inaccessible, those areas where the instruments could not go, but now with the advent of robotic system we are able to. And then the precision has increased. All of us know, as the technology is advancing so fast, so much of precision is there. At the moment, can you imagine, even the staplers initially in our system in Glangaram Hospital, we have a system in which was SI. I told in the last lecture also that we had to rely on the assistant who was standing by the surgeon's patient side. He had to fire the stapler and he could misfire also. But now the stapler control is also in the hands of the surgeon. So thinking is that ultimately the progress is going on in a large scale, and ultimately list is expanding like anything. These many procedures have already been done robotically, and if you say that it is not going to stay, I think we are fooling ourselves. And in our center, most procedures we are doing mainly for the obesity. Definitely, I would say that I am not for robotic cholecystectomy. I know that I do all my choles single incision lap choles. So if I say that I will do robotically, that means I will have to make 4 ports, and 4 ports robotic chole versus single incision lap chole. I know that I finish off single incision lap chole in 20 minutes or 25 minutes. So why should I go back? Why should we patients spend so much for my robotic surgery? So ultimate answer is that we should decide that robotics is not for hernia, normal hernias, but they are for complex kind of hernias, for the complex surgeries. For example, in the pancreatic cancer, if one has to do the hepatogenostomy, if one has to do the anastomosis, if we can catch hold of the sutures, it becomes beautiful. If you are operating on a roof and doing the suturing, it does not appear that it is difficult at all, because ventral hernias. So thinking is that those areas which we were finding difficult in laparoscopic surgery, this is the tool which is definitely helping us. And I did only one robotic chole when we started our career of robotics. So I did one robotic chole to start with as Ganeshaya Nama types, and then after that we have, but ultimately we realized that it is not at all difficult to learn robotics. 25 cases of robotics to sit on the console, to do the footwork, it becomes easier, and then one can go on with all the procedures. And then we did fundoplications, ecclesia cardias, ventral hernias, but ultimately our aim was not to stick on to the Borgagni hernias or anything, but our thought was that we should focus on obesity and focus on, especially for high BMI patients, or robotics has a beautiful place in revisional surgeries. If somebody says that with robotics there will not be any complications, no, there are complications also. Now these kind of abdomens, when we were tackling, these are definitely helped when it is so much of fat is there and so much of torque. This is a 84. Now you see, this was the same patient which I told you that we had a bubbles coming out in 84.6 kind of BMI. And in this patient, if the leak would have been missed, then we had it. So she would not have been able to survive even. So our thinking is that these kind of abdomens definitely they become easier. And now you see that from what weight to what weight they come, and definitely these helps. And again, there were surgeons who were opposing the robotic system, telling yes, because docking takes time, undocking takes time. No, it is a team effort. It is a team effort. It takes few seconds now, few seconds. Whole of the team knows that it has to be docked from the top head end, or it has to be docked from the sides. So ultimately, once the systems are working, once it is protocolized, then it becomes very, very easy. And instrumentation also, the advent of harmonic, for example, energy sources have come out, and definitely they have helped. Now in this small video clipping, I will just show that ultimately, all said and done, we are replicating the procedure as we would have done in laparoscopic method. For example, small nits and bits are there that you have to be having a distance from first arm and the R1 and R2, but ultimately, let's be very straight about it, they are learnable. One can always learn that, and once you are able to master which is the fulcrum point, which is the T point, and ultimately you are able to go in, you are able to replicate the similar procedure. So thinking is, now you see the best part of the story is that the 3D vision is excellent. Once you are sitting on the console, you are having the eyes on in the console, and then the 3D vision is definitely that helps. And plus instruments, cost of the instruments. We in Gangaram Hospital, for example, we charge 1 lakh rupees extra as compared to laparoscopic surgery. So ultimately, people come from Kenya, from Australia, from all the outside countries also. They want robotic sleeve gastrectomies or robotic bypass. We do it because we know that we have been trained to do, and then ultimately it becomes easier. As we believe that check endoscopy is very, very important. Now these kind of patients, he is 280 kg, and if one does the robotic work, and then after that the patient is able to move from the table to the trolley, and in the same evening we ask the patients to roam around, move around, because of the less requirement of pain also, and then next day when they are moving, that definitely gives a comfort level to us. So ultimately answer is that yes, we should harp on to this kind of wagon. Because you are young, if you do not, then you will be too late for that. And then we had publications also on robotic sleeve gastrectomy in morbid obese patients versus super morbid obese patients. Ultimately, we realized that the time which we were taking for doing the sleeve gastrectomy laparoscopically versus robotically, definitely we were getting closer to the time which we were spending there. But in some situations, when the super morbid obese patients were there, definitely the time is becoming less and less in if we would compare with the laparoscopy. Similarly, gastric bypass has also been compared, and the leak, more important than anything else. Lot of studies are there. I'm not going into the details of it, because of the vision, because of the ease of the surgeon, because of the ease of the instrumentation, the anastomotic leak and stricture have also been proven to be less in robotic system as compared to the laparoscopic system. So that becomes advantages. The hands-on gastrostomy, that becomes advantages, that we are able to do this kind of maneuvering. Maneuverability becomes easier, and definitely the patient is benefited a lot. So thinking is that yes, we should definitely know. And as I showed, I think this is the same video clipping that I showed, that one should do the check endoscopy on the table. If the leak is there, one can just put in a suture and that's it. The patient does the same way as if the leak was not there. So we had Dr. Vivek had also presented this article on robotic assisted gastric bypass, a 5-year experience. And so many publications have been there in Journal of Minimal Access Surgery, but ultimately I would still say that carry on unlearning, learning and relearning. And again, I would not love to dwell on the topic of endoscopic bariatrics, because I have not done it, and I do not, honestly speaking, I may be the laggard in that situation, that I found that there is not much benefit in offering the endoscopic sleeve gastrectomy because of the ghrelin, because of the fundus. If you are able to do the suturing from within, and if you think that yes, your patient will have the same amount of weight loss, at least I have not been able to be sold out. But again, I would say that we should not have that closed mind. We should definitely have the open mind and learn these things so that we are able to give the best. Now, similarly, as Dr. Ranjan Sudan, he is very close to us, he also wrote an article on sleeve gastrectomy strictures, and stricturoplasty has been done. So our thinking is that yes, in revisional surgeries, definitely this kind of equipment helps in revisional surgeries also. And that definitely the journey continues. And now, because of the firefly, all of us know that because of the drugs and which we give and inject, and we are able to see. And can you imagine, in surgical oncology also, they are finding the use of firefly a lot, that when they are injecting the indigo carmine and then they are seeing the vessels or the structures or the leaks, everything can be seen. So ultimately the progress is occurring, and it is occurring at a very fast pace. So we should be definitely be ready, and we should be smart enough to go in for artificial intelligence also. Means artificial intelligence would mean, for example, you are sitting on the console of the patient and you are able to see the MRI, you are able to see the CT scan, and you are able to see the inside field also. So ultimately, aim is that we are not going to go, and these are the companies. For example, now iWeb Surgical, that has been adopted by Ethicon, Johnson Johnson and Google. They are also working on the systems, and the time is not far off that Medtronics has already come. Google is also trying its best, and Ethicon, Johnson Johnson, Da Vinci, and so many companies are going to come, which is going to change the total scenario. Thank you very much. Any questions, more than welcome to ask.